Hi, my name is Amy Albu. I'm a nurse in the Surgical Trauma Burn ICU at University of Virginia Medical Center. I am giving a short presentation on catheter-associated urinary tract infections, or Cautis, and ways in which we can prevent these infections, decrease our infection rate. I presented this material to my clinical instructor at Allegheny Medical Center and also to some of the unit managers there. They were quite receptive to the information that we talked about, so I feel that it was an effective presentation, and hopefully if they implement these protocols as well, they will see the changes that we've seen at UVA. Approximately 2 months ago, we changed our protocol just a bit with in regard to pericare and Foley care with our patients. Since then, we've gone about 55 days without having a documented catheter-associated urinary tract infection. So I'm going to just go through with you the procedures that we use there, and they're going to seem a little bit tedious and also a little bit basic. It really goes back to what we've learned in nursing school, and but I think it's just important to really go back to the basics and ensure that we are properly cleaning our patients, that we're properly assessing our patients, and swiftly taking action to either prevent or treat these urinary tract infections that do take place. So with that being said, I'm going to talk about our standard protocol for pericare. And the only thing that's really different about this is that we've just added a couple steps. We've started washing a little bit more in between, and we also use chlorhexidine bath wipes. So we use these for our baths with all of our patients every shift. So Q12, we use these. They come in, one large pack has 3 little small packs in it, and then each small pack has 2 wipes. So you can use one wipe for pericare and one wipe for Foley care. And so as far as pericare goes with the patient, we just want to ensure, the first step would be to ensure that we are ready, that the room is ready, we've gathered all of our supplies, that we have our linen basket nearby, our trash can nearby, and we want to ensure the patient's privacy, and we also want to ensure that we have enough help. On our unit, we oftentimes have very sick patients, and these turns and cleanups need to be done briskly, and so we don't want to overlook cleaning them well, so that's why it's important to have enough hands with the process. So initially we will wash and glove, and then you will contain the stool and cleanse your patient with the chlorhexidine wipes. At that time, you will discard your soiled linens, you will discard your soiled gloves, you will wash your hands and apply new gloves. At that time, you will place your clean linens and apply a barrier cream or any other kind of ointment that might be prescribed for the patient, or a Mepilex as well. We use a lot of those at UVA. And let's see, after that, you will wash and re-glove again, and you will start catheter care on your patient. So you will clean your patient from the urethra down to down the tubing with one chlorhexidine wipe, or down the catheter, sorry, with one chlorhexidine wipe, and the other chlorhexidine wipe would be used to wipe down the tubing all the way down to the bottom of the bag. At that time, you want to ensure that your Foley bag is securely attached to the bed and not hanging from a bed rail or dragging on the floor or anything like that. You also want to ensure that it's attached to the patient's leg. So we use these nice stat locks that hold very well. They secure very well. They don't seem to be too harsh on the patient's skin, and you can remove with an alcohol wipe that removes it quickly. So, like I said, we do catheter care Q 12 hours, and also some of the other things that we need to talk about as far as protocols go would be obtaining a urine culture or specimen. So some of the things that we've talked about and that we have found effective on our unit would be to ensure, of course, ensure that the patient needs a Foley catheter. Every day you want to assess your patient for that. Do they still need it? Are they able to urinate on their own? Are they critical? Are they incontinent? All of these things need to be discussed, need to be assessed and discussed with your physician on a daily basis. When the patient presents with an infection or with a fever that's an indication of infection, that would be a flag to culture the patient. So we would go ahead and go through a protocol that they've set or an algorithm that has been set for us as far as when to actually culture a patient and when to wait. For us, when a catheter has been in place for less than 48 hours, they spike a fever, or they have suprapubic tenderness. These would all be indications that the patient would need to be cultured. With that being said, if it is a catheter that was placed by urology, if it was a difficult insertion, which happens to us quite often, we would also, sometimes they have different access ports and stuff, so it would be difficult to obtain a specimen. So we would have to just consult with urology if that was needed. Also, like I had previously said, we want to make sure that we do indeed need the catheter in place. If they present with an infection and the catheter if the patient seems like they would be fine without the catheter, if they're if they're waking up and able to urinate on their own, or seem to urinate on their own, then we would pull the Foley catheter and attempt to do that. So should we need to culture them, we would have to take a good measure to not overdo this, because accessing the port too much can, of course, introduce more bacteria into the catheter. So we just take care to not, if the culture's previously been done within 24 hours, we will not do it again unless the physician really wants it. But you will scrub the port thoroughly, you will attach a 10 cc syringe, withdraw your 10 cc's of urine, and then transfer the urine into a sterile specimen cup with a lid, and then transfer that to the lab. Now, if the lab gets this specimen and it has been timed for greater than 2 hours, the lab needs to discard this, and you would have to obtain a new specimen. So I think the most important things to take away would be that we just need to be more aware of the significance of Foley catheters and the infections that can be quickly present in our patients. We need to be aggressive in removing these catheters if it's at all possible. If it is not possible and it presents more of a risk to the patient's skin, then we just need to take care to document thoroughly and to keep each other accountable for documenting and providing care as appropriate. Thank you.